Am I good to go?
Yes.
Okay, thank you. Hi, everyone. So nice to be here today with all of you. And I hope that I can just share with you my experiences and that it has meaning for your, as you teach. I am Nancy Prusing or Pressing. It depends on what day it is, whether I say Pressing or Prusing. Um, my presentation is about orientation and mobility with seniors and adults and things to consider in this. Most of my career has been with adults and seniors, and my degree was orientation and mobility with the working age adults. And let me just tell you, I did not come to this profession early in life. I have an undergraduate degree and it was in music, but I didn't believe that I could exist in that world of total competition. And I played the violin and I really didn't like orchestra music, come to find out later. So I just floundered around for trying to find my niche in the world and the best job for me. And I didn't. And then my grandmother's lawyer said, "Oh, um, by the way, if you want to go back to school, it's paid for." Apparently, my grandfather took out a trust fund for education, and I didn't know. So, my last awful job was at the tax department, the Virginia tax department, Virginia's Center for, anyway. And I floundered for a year in that position. I hated it and I've never done my own taxes and I can barely add and subtract. And so I wasn't gonna last. And that's when I looked at the whole issue of school seriously. So I re-enrolled at Virginia Commonwealth in rehab counseling. I'd taken a few classes there before. I had no idea what I wanted to do. And so I just re-enrolled out of desperation. And I began to work part-time at one of the departments in the tax department that was mildly interesting. And I was taking a blind girl to work on Saturdays. She lived a block from me and she worked in the same place. And we always had a nice conversation. And one day she said something about her mobility specialist. And I didn't know what she meant. And so I Googled it, and all I got were things about car races and what have you. And I dug a little further, and I, I just learned that Western Michigan had a year's program. I learned that it was all about the white cane or travel skills and what have you for people who are blind. But what really got me to apply was they didn't require the GREs and it was only a year program. So I could be reasonably certain that I could get out and work towards my retirement. So I applied and I was accepted and given in-state tuition. And so off I went. I quit all of my jobs. I left everything for a year, packed it all up, and off I went to Western Michigan. And it was the best year of my life. So I was just talking about Virginia, but born and raised in Richmond, Virginia, as I said. And the awful job is what got me to go back to school. And so here's my transcript. And once I finished my Western Michigan degree, I got a job in the field, but I also went back and finished my rehab counseling degree because by now I was kind of on a roll with that. And I just kept going to school because I sort of liked it. All of a sudden, people wanted to know what I thought, at least in the form of a paper. My first job was with children, and I was so proud and so pleased. I got the job right after I wasn't even done with my internship, I don't think. And I just, got the job and moved from Hines VA Hospital to a small town in Wisconsin, and I started the job. And there was no training, and I hadn't worked with kids, and she just handed me the IEPs and said, see ya. So that was kind of my orientation, and it was really hard to adjust to. Eventually I got into it, and it was okay, but I lived in an apartment, and if you'll notice, my kitty is in the lower left-hand corner. There is my kitty cat looking outside for whatever bird action there is. So I did that for a year, and then I was called to go back home to Richmond. And the reason I did that is because my mother was really ill, and I knew it wasn't, I needed to be there. And so I also knew that I would get really good training if I worked at a rehab center. So I applied for and got a job at the Virginia Rehab Center for the Blind and Vision Impaired. And it was a wonderful job. It was a center-based agency, and I had great coworkers who were instrumental in what I learned. And I was able to get certified in low vision because we were the case managers for all of the low vision needs. So it was very easy to get certified in low vision for that. I finished my rehab counseling degree, and I enjoyed my family. And then my mother died, and I floundered for a bit, as anyone would. And I quit the rehab center because I thought there was something else. I don't know, I'm called to go back to my old house in Wisconsin and what have you. Ultimately, I ended up at the Minneapolis VA Medical Center, in Minnesota. And I worked as an O&M in the VISOR program. I did low vision, and I also did vision therapy under the direction of Dr. Pruitt. And if anybody knows anything about vision therapy, it's so interesting, but it's all about helping folks who've had head injuries and trauma and blast injuries specifically to deal with diplopia or double vision or not smooth reading, not what we call motility. No, I'm not motility. Anyway, just not reading well or accommodation. And I did this position for a while, and then I applied for the VIS coordinator position, and I got it. And the VIS coordinator at the VA Medical Center is the case manager for the legally blind. And at the end of the program, if we have time, I want to explain to you, in case any of you know any veterans, just some things that I picked up that you may want to know about getting into the VA if you're legally blind and that kind of thing. So I was there for 7 years and 10 months. And then I transferred back to Richmond for the Polytrauma Bros blind rehab outpatient specialist position. So my father was alive, and he was in Richmond, and I just had to go home and help him. And I did get there in the nick of time because he died 5 months later. But even though I had to be certified in low vision and mobility and things of that sort, in other words, blind rehab, I was working with brain injured people 24/7. And I wasn't necessarily in close proximity to someone who would tell me what to do, which Dr. Pruitt had done. I was working on my own. So I was responsible for evaluating and making recommendations and also teaching and training. And I would get guys with double vision, and what was I doing? So I went back to school. I went back to Salus University in vision therapy, and it was a wonderful program. And it really helped me to effectively do that job. So the first thing I did when I got into that position, and I didn't know what I was doing, I didn't even know what what to do administratively in terms of paperwork and what have you. So everything was a learning experience. But they asked me to order anything that I needed. And I ordered some things to evaluate for that population, but I also ordered every color of noir tints that I could even possibly get in something other than the U frame, the 38 frame, or the N frame. And one of the main conditions that people were referred to me for was light sensitivity. And over time, I became known as Nancy with the magic glasses, because these veterans had been exposed, to a blast injury and head injuries and what have you. And they were extremely light sensitive, and they would have serious headaches along with that. And oftentimes, just getting the right tint, nighttime, inside environment and outside environment, just would help to reduce those headaches immensely. So that was a very satisfying finding. And I did enjoy that experience, and having some gentleman that I don't remember having helped at all come up to me and say, my headaches are 50% down. Thank you so much. That was just the most rewarding and satisfying experience. And then I retired and I moved north, and I now work for myself. I contract. My LLC is called Vision Matters LLC. And I also work at the Wisconsin Center for the Blind and Vision Impaired. That's where Megan works. And I absolutely love it. I didn't think I would like to work with kids as much as I do, but I really do. I just love teaching mobility. So let's talk about adults and seniors. And where did we start with this one? Let's look at our senior population, because I did a little research on why this was really important for us now, and it's kind of interesting. So the silver tsunami is a term that is currently used to describe our aging population around the world. The 2020 census revealed that there are 55.8 million US citizens over the age of 65. And by 2030, the entire baby boomer population will be at or beyond the age of retirement. It's the first time in our history that the 65 and older population will outnumber the 18 and younger population. And that's because over the past 50 years, family size and birth rates have decreased significantly. Did you know that during World War II, 10,643,238 soldiers returned home after serving in the US military? This population was known as the greatest generation, and it is the one that precedes the baby boomer population. Anyway, that was the result of their return was an explosion of babies. The number of individuals born in the 2 decades, that would be 1946 to 1964, was 76 million, or 40% of the population. And this was the largest generation in our history until the millennial generation just passed it. Roosevelt and, all of the government didn't know what to think. We had just gotten done with the Great Depression, and we didn't want, to go back to that with all of these servicemen coming back and having nothing to do. So the GI Bill happened. If you served in the military before the GI Bill, you were on your own when you returned home. Housing, job training, and education were up to you. And apparently, housing and education were not available to the average American prior to World War II. So The middle class really got its origins because of this. During World War II, the Department of Labor determined that 15 million men and women would return from serving and be unemployed. In an effort to prevent this, the National Resources Planning Board reviewed post-war manpower needs and then presented their recommendations for education and training programs in June of 1943. And the American Legion was responsible for designing the main components of the GI Bill and ensuring that it got passed through Congress. And I think this is interesting because I have gotten a CCTV for a 55-year-old who was not intent on working again, too ill to work, and the American Legion supplied it. So it is an avenue for getting certain things that you might need, and that's an FYI if you didn't know that. So anyway, the GI Bill passed through both chambers of Congress and was signed into law by Roosevelt in 1944. The purpose of the GI Bill, it provided federal aid for home purchases, businesses, hospitalization, and education. The act provided for tuition, books and supplies, equipment, counseling, and subsistence or food. The GI Bill created a ripple effect across the economy, and it warded off concerns about another depression. And actually, it created unparalleled prosperity for a generation, quote unquote. The GI Bill was extended into Vietnam and Korean wars after that. And then the post-GI Bill was passed in 2008. And then recently, the Forever GI Bill. When the initial GI Bill expired in 1956, $14.5 billion had been distributed to veterans for education and training. And by 1955, 4.3 million home loans for a total of $33 billion had been granted. I thought that was really interesting. And in the next 7 years, about 8 million veterans received educational benefits. That would be 2,300,000 attended universities or colleges, 3,400,000 received on-the-job training, and 3,500,000 received school training. The number of degrees issued by colleges and universities in the U.S. more than doubled from 1940 to 1950, and the number of Americans who earned an advanced degree went from 4.6% in 1945 to 25% in a half century. I think that's significant. Apparently, our ancestors didn't go on to college very often. And come to think of it, that's true when I think back to my relatives. Well, the GI Bill was not necessarily great for everyone, and I thought this was really interesting. While the GI Bill itself did not exclude minorities, it was structured in such a way that did so. 1.2 million African Americans had enlisted during World War II, but benefits of the GI Bill, tuition, business loans, and mortgage support could and were denied to them after they served. So how did this happen? It wasn't necessarily obvious, but redlining was rampant, and postmasters sometimes were accused of not delivering the unemployment information. Southern colleges refused entry, and Northern colleges just stalled. And white financial institutions, predominantly white, refused loans to African Americans. So most good jobs were given to white individuals. So this is hard to think about, that this is my generation, basically. And I mean, I'm a baby boomer, but I just can't imagine that such treatment existed, Anyway, so let's move on to blindness, because this is also a big issue right now for all of us, and that's why we're here. What are the worldwide stats on this? This was really shocking to me. The primary causes of visual impairments worldwide are uncorrected refractive errors, glaucoma, macular degeneration, diabetic retinopathy, and cataracts. 2.2 billion persons suffer from a visual impairment, distant or near, and about half of this total could have been prevented or still could be prevented. The annual lost cost, or what we lose globally due to blindness or a visual impairment, is estimated to be at about 411 billion US dollars. That's a lot of money. But here's what is really shocking to me. The primary causes of blindness at a global level are refractive conditions and cataracts. Refractive conditions. Estimates conclude that globally, 36% of individuals with a distance refractive error and only 17% of those with a visual impairment secondary to cataracts had an appropriate intervention. About 80% of global blindness could be treated or prevented. Visiting an eye doctor for an eye exam on a regular basis is so important. It's hard to believe. The National Eye Institute estimates that about 8.2 million individuals in the United States had problems with their vision to an uncorrected refractive error, while 3.2 million Americans had an uncorrectable refractive error, and about 1 million Americans were legally blind. So think about that. How many people do you know that know what presbyopia means? Or, I mean, I work at Duluth Trading for the discount. It's just a retail job and I enjoy it. And it has a pretty educated group of customers. And I might mention the word presbyopia or something, or maybe I explained or talk about what I did, or comment on their glasses frames, or ask them how they like their bifocals or something like that. And they have no idea what presbyopia means. So it makes sense. And how many times did I meet a 40-year-old something or other brain injured veteran who said, I'm just getting old. And I would let them know, that, yeah, you're 40 years old and you're not getting old. I'm here to tell you, you're not getting old, but you do need to get reading glasses. The only thing is an age-related change of the lens of the eye. So more than 93 million Americans were in 2017 at high risk for vision loss, yet only 56.9 had visited an eye care specialist each year, and only 59.6 had a dilated eye exam. For those who needed eyeglasses, an estimated 9 out of 100 could not afford them. Not only does this suggest that a high percentage of those at risk for vision loss are not adequately screened, but that individuals at risk for vision loss do not even receive eye care. 40% of Americans who were at risk for vision loss did not even receive an annual eye exam. So I do remember working at the rehab center for the blind in Richmond, and I had 2 African Americans referred to me who were blind because of glaucoma. They had no idea that they were becoming blind. Glaucoma is a silent blinder. And one of those clients mentioned that he thought he had an eye exam, that the DMV acuity check isn't that an eye exam? And to me, that is, we got to do better than that. Somehow, students, kids, they all need to know what to look out for, when their eyes are going to change, what is a refractive error, when to go see an eye doctor, etc. But to me, that was just a terrible realization that both of these cases of pretty bad blindness could have been prevented if you'd only gotten an eye exam. Moving right along, the main causes of, hold on, I need to move this panel. In the US, the main causes of blindness are diabetic retinopathy, macular degeneration, cataract, and glaucoma, in that order. And amblyopia is the most prevalent cause for children, but for adults, it's diabetic retinopathy. And it's the leading cause of blindness for adults in the US. Yet refractive errors are the most frequent eye problems. While blindness and vision loss can affect individuals at any age, most visually impaired or blind individuals are over the age of 50. So let's look at that. For those who are at high risk for vision loss, according to the CDC, this will increase from 65 million to 93 million. So I'm sorry, it increased from 65 million to 93 million between 2002 and 2017. And 4 in 10 adults are at high risk for vision loss. And as noted, 40% of those at high risk for vision loss did not receive an eye exam in the past year. Over 8 million adults who know they need eyeglasses said they could not afford them. So that must be that 9 out of 100. That to me is surprising. Moving right along, let's talk about age and vision. Over 12 million Americans over the age of 40 have a visual impairment, and 1 million Americans are considered to be or deemed to be legally blind. Our rapidly aging population is going to increase that number of Americans living with a chronic condition that can lead to blindness. And thanks to the aging baby boomer population, the number of citizens with blindness is expected, and visual impairment is expected to double by 2050. And that's according to a review of the census data and some reports and studies that the National Eye Institute did prior to 2016. And the economic impact of vision problems here in the States by 2050 is expected to increase to $373 billion. I did not look at what the economic impact is today, or I just didn't document that. So aging as well as population growth could cause an increase in the rate of acquired visual impairment. Now, for any of those who know someone who is blind, they usually weren't born blind in the older age category, at least not seniors and adults that I have worked with or known. They usually became blind secondary to macular degeneration or something of that sort. And that visual impairment severely impacts the quality of life of any senior or adult, resulting in social isolation, walking problems, risk of falls, the possibility of nursing home and other care early entry. You know, the change that late in life is really difficult to fathom or experience. Personal impact of vision loss affects every age. Children with early onset vision loss may have delayed motor, language, cognitive, emotional, and social development. And school-age children have the potential for a lower level of educational achievement, The impact for working age adults is lower rates of employment and higher rates of depression and anxiety. And I'm sure pay could enter in there too. And the personal impact of blindness and vision impairment for older adults, again, is social isolation, risk of falls and fractures, problems with mobility and walking, and a higher probability of nursing home and nursing home care entry. So I want to talk about those eye conditions, and this is up close and personal to me when we're talking about refractive conditions. But for basically refractive errors and cataracts, macular degeneration, glaucoma, and diabetic retinopathy, I would like to just talk about that for a little bit. Do you have a client or know someone who has a field restriction who just had an eye exam and was given a pair of bifocals by their eye doctor? Has anybody had that experience? I know nobody can say much, but I have. And he might have only had a 5-degree field of view, but and he couldn't get the ad portion of that bifocal. The ad portion is the portion where they read through, and he couldn't easily look down and see through that portion. And it was all because he didn't have a low vision optometrist. That's what even though the doctor knew he had glaucoma, it didn't result in an appropriate pair of glasses. And somebody with a really small field of view would do better, if possible, if they still can, if the magnification isn't too much, but to get reading glasses for reading or other needs. So not all doctors or optometrists or ophthalmologists can work with our population. So as I have gone along, optometry is so varied. An ophthalmologist, I haven't had much exposure with that because I was usually functionally oriented, but for the most part, it's my understanding that ophthalmologists predominantly do surgery now, and optometrists do a lot of the prescribing and other factors. And if we break that down, there are still 10 types of optometry specialties: contact lenses, myopia or nearsighted control, pediatric optometry, vision therapy optometry, geriatric optometry, low vision, sports vision, and ocular aesthetics. I'm not sure what that means. And a note on behavioral optometry, that's kind of what I did. It was very interesting, and check it out. A behavioral optometrist is going to be the one who can prescribe prism glasses. And if you have someone who had a stroke or a head injury or a concussive event, they may have difficulty with saccadic eye movements secondary to the muscles being messed up in their eyes, or they may have double vision. And prisms is all about correcting that muscle imbalance. Sometimes therapy can help with that, but if their doubleness is vertical, it's all about prisms. If it's horizontal, that's what I did as a vision therapist. You can correct that through eye exercises, but not with a vertical misalignment. So not all optometrists are equal. And if you run into an issue where it doesn't seem that the optometrist can work with your client or doesn't know that much about low vision, it's probable that their specialty is in another field. Let's talk about cataracts. Cataracts are really common for individuals over the age of 40. 24 million individuals are affected in the US. The cause of age-related cataracts is a breakdown in the protein of the lens of the eye. And this is the part of the eye that helps light to focus an image on the retina behind the iris. So if you have cataracts, it is like driving into the sun. it's really hard, you're just flooded with glare and lighting, and you just can't see that well. And cataracts should be removed when they begin to affect activities of daily living. Now, I haven't checked into this recently, but when I was going through school and later, it was understood that cataracts would be taken out when the cataracts got to a certain point clinically. However, if you're noticing, I remember caning chairs. I was taking a class in chair caning, and this older woman said, "Oh yes, my eye doctor says I have cataracts, and but they're not bad enough to operate on now." And I just mentioned that, well, maybe I can help you. Sunglasses might really help, and I have a lot of different colors that might help you with night driving and what have you. And she said, I'm fine. The next week she came back and she said, I want the name of a different doctor. Not like that was going to really help, but I had an accident. It was my fault, and I just didn't see that car. So I encourage anybody who is experiencing trouble with glare and lighting to bitch about it and to report that to your eye doctor. And notice when you have trouble with that, driving into the sun, night driving, anything where you are blindsided because of glare and lighting is noteworthy as a cataract. It's in our country, by the way, women and those of white descent are most likely to experience cataracts. Age-related cataracts are common. However, cataracts can also be inherited. So just keeping that in mind too. In the United States and for people of all ages, the annual prevalence of cataracts is 17 out of 100 individuals. Cataract removal is safe and effective and is one of the most common outpatient procedures. 9 out of 10 individuals see better after cataract removal. I meet a lot of people, and they are in the process of having cataracts removed, and that person is awesomely excited about the improvement. Doctor says this eye is 20/20 now. Can't wait to get this eye taken care of. I'm going to have that done in a month or two. Anyway, while cataract removal is common in this country and very simple to do, cataracts cause severe vision loss in areas of the world where treatment is not available. Again, it is associated with risk of falls, fragility, depressive symptoms, and neurocognitive decline in the elderly generation. So if you are working with an immigrant population, please refer to get them an eye exam quickly. They probably don't have a good set of glasses. They probably are experiencing cataracts in general, I would say. The World Health Organization estimates that 94 million individuals worldwide have a significant visual impairment secondary to cataracts. And that is mind-boggling for me, given how safe and effective it is. Okay, moving right along, let's talk about, all right, I already said this. Does the general public know and recognize what a cataract is or its symptoms? Probably not. Again, you might want to educate anybody on what a cataract is and what you should notice, especially for those over the age of 40. Okay, let's see. Cataracts and mobility. In my experience, the only experience I've had with age-related cataracts before surgery is the woman from the Cane Connection that had the accident. And I have not experienced any mobility concerns usually. But if you're working with someone who is not yet a candidate for surgery, be sure to evaluate anything that can improve contrast. Go to a lighting store to check out different light bulbs. let them try each light bulb individually and see how it works on an acuity chart or something. Which one is better for contrast or just something of contrast. Get your glare glasses out. Evaluate those in different environments. Check out, turn off the light and see if you can decrease that blinding glare from the oncoming traffic. Shine a flashlight, let them try a different set of glasses on. Evaluate the effects of various lit environments on acuity, and advocate for some complaining. So if they like their eye doctor, they might just, say, I'm missing the steps, not seeing the bottom step as often. It's really hard in light changing. By the way, red tints seems to do well with light adjustment from red to dark. Now let's talk about lighting. Do you know that a 65-year-old requires twice as much light as a 20-year-old? This was really interesting to me because I tend not to like overhead lights, but my significant other always walks into a room and turns on the overhead light. And I realized that he's getting up there. So he's probably not able to see that well because, now that we're older, we require more lighting. That said, how many of us seniors really know that and accommodate for it and put in different light bulbs or extra lighting or lighting strips around our doors? I bet we don't. And let's talk about macular degeneration. Now, I have to tell you that this was so prevalent, at least at the VA. And I think I got more bitching with this one than any other eye condition. Let me tell you about the time I was helping with the golf tournament at the VA golf tournament thing. And I went into some bar for dinner, and this man was sitting at the bar all alone, bitching to the bartender about how blind he was. And I'm so blind, I can't see a thing. And I just happened to say, well, if you're that blind, maybe you need a white cane and work with somebody like myself. And all of a sudden he says, I'm not that blind. And so I knew what he meant. He had macular degeneration and he couldn't read a thing easily. Maybe he could if he could view eccentrically and find that one spot that was capable of seeing clear vision, but not much of it. And, he just wasn't going to do it. So I expect resistance, especially if it's macular degeneration. I expect resistance because seniors, they became blind and they're still in their mourning and denial phase when I see them. So we've got to work around that. But macular degeneration seems to be the one that is more troubling for many. Speaking of that, I have to tell you about the man with retinitis pigmentosa. And he was significantly constricted. And I remember doing an evaluation on him and walking all over the VA. He denied the need for a cane. And I just explained to him that it's much safer on steps and in new environments and areas of low lighting and all of this. And he says, no, I don't have any problems at all. So I observed him and we walked all over the hospital, all over the place, upstairs, downstairs, outside, by the curb. He didn't miss a beat. Then we went back to our starting point near the eye clinic. And the elevator section at the Minneapolis VA is big. It's a huge area. It's a huge open room with 3 elevator doors right there. And there was one other person standing in that huge area. And my gentleman stood this far away from him. It couldn't have been more than 2 or 3 feet, which if you were to do that where I came from, oh boy, that would get me into big trouble. You're invading somebody's personal space, and he had no idea that man was standing there. And that man just looked over to him like, what are you doing? So there's a man in denial. So that's all I got to say about that one. Anyway, back to macular degeneration. The Cleveland Clinic claims that about 20 million Americans suffer from wet or dry macular degeneration. It is the leading cause of vision loss for individuals 60 years of age or older. There is no cure at the moment. Sorry for the typo there. The macula is the center of the retina, and it accounts for all of our central vision, which we use for reading, focused tasks, recognizing faces and colors, etc. Gradual vision loss occurs with the dry form of MD, which occurs in 90% of that 20 million Americans. And the wet form or exudative form is more severe, and it can rapidly cause a loss of vision. It occurs when a blood vessel develops under the retina and the macula. And there are treatments that can slow the progression of wet AMD, and dry can turn to wet. So if somebody is noticing a loss of vision and they say, well, there's nothing they can do. If they had the dry form, it could progress into the wet form, or they could be having another blood vessel develop under the retina and the macula, and it needs to get taken care of quickly. So just make sure that your individual knows this and gets to an eye doctor as quickly as possible if they notice any changes, especially if they have the dry form, because they probably know that if they have the wet. I understand that anti-VEGF drugs can stabilize or improve wet AMD, and certain supplements can slow the progression of dry AMD. But I do hear people say that it is helping, or it does seem to be slowing it down. But, you know, it's still a difficult condition to live with. I have not noticed that there is a history of falls with macular degeneration. And I think a former colleague explained it to me, and he has since passed, but so I wasn't able to check in with him. I never questioned his comments because he was usually spot on. But he always said that you use your peripheral vision for movement. And so macular guys didn't necessarily need a long cane, at least early in their disease. So I always recommended a support cane for the purpose of identification. And, you know, you might want to evaluate that and see if they can, you know, they get all of the things that might get in their way. Are they catching the steps? Are they running into people, running into obstacles, getting too close, tripping on the curb? Is their toe going too far over the curb? And by all means, give them information on the white cane law, which is anybody with a white cane has the right of way. And that's crucial and significant. It means that you can mess up out there on city streets, but you still get the grace around it. So you're not liable for it. While I would expect someone with macular degeneration, I would probably refer them to a center-based agency as soon as possible, because the vision loss has come on kind of suddenly, and they're going to need more than just orientation and mobility. They're going to need the full program, most likely, especially low vision, especially living skills and cooking and things like that. So I'm an advocate for adults and seniors going to a center-based agency, because it's so useful for the case of adjustment. Let's see what my next slide is. One thing you could do if you're working with someone who has macular degeneration is show them how to use the Amsler grid, just to notice any new changes that they might not notice. And there are directions and instructions on there here, and I got this off of Cleveland Clinic, but you could, sometimes when you're looking with both eyes, you're not aware of changes that happen in one eye, and they might want to be a little more proactive in tracking any future vision loss or vision changes that they can get on top of and perhaps treat. Let's talk about glaucoma. And this is known as the silent blinder. It's an eye condition that damages the optic nerve slowly and over a period of time. Closed angle happens when the iris eventually blocks drainage, causing intense and sudden blur, headaches, severe eye pain, halos, etc., and it is an emergency. There could be no symptoms until damage is too severe or there is an attack. I found it very interesting. There was a German website that I included here, Fedorov Restore Vision Clinic, that states the actual definition of glaucoma is evolving and that it is more of a primary vascular optic neuropathy as opposed to an issue of interocular pressure. I don't know what that means really, but I just find it interesting that it's something other than what something a little bit different. The only way to know if you have glaucoma is to get an eye exam, a dilated eye exam. There are no symptoms in the early stages of this eye condition, and you don't know that you have glaucoma until you have lost vision. It is treatable. Treatment can prevent vision loss, but it can't reverse what's been lost. Medicine and surgery are effective in preventing further damage, period. I do know that the glaucoma medicine is often considered painful and people don't like it, but oh well. It is the most common blinding condition for African Americans, and this is noteworthy. I presume that given the history of the baby boomer population, that a lot of African Americans don't get a regular eye exam, and that concerns me since this is such a prevalent condition in their population. And the CDC recommends a dilated eye exam every 2 years for anyone at risk for glaucoma. Shoot, I would go every year. And who is at risk for developing glaucoma? Those with an elevated IOP. Prevalence increases with age, 40 for African Americans and everyone over 60. And diabetic, hypertensive, migraines, poor blood circulation, or other systemic conditions have a higher likelihood of developing glaucoma. As noted, African, Hispanic, and Asian culture, lower prevalence for Caucasians. And if you're farsighted or nearsighted, you have a greater prevalence of developing glaucoma, or a family history, a history of eye injury, or long-term use of steroids. Or if you have a thinning of the optic nerve or thin-centered corneas. I don't know how you know that. Usually individuals with glaucoma have more of a visual field loss initially. So how can you help if they deny significant difficulty? I would just start with glare and lighting. And I do remember evaluating light bulbs back at the rehab center, and the gentleman found the pink bulb to be the most useful for him visually. It gave him greater contrast and greater visibility. So he used it in a reading lamp. And this is a long time ago. I'm sure the light bulbs have changed from then. If we have time about it later after questions, I'll just tell you what I learned about those. But definitely going through Farm and Fleet or another lighting store and looking at those light bulbs is a good idea. So evaluate glare and lighting, start with pink, just go for a walk and provide recommendations as you see the need. Is, how do they notice curbs and drop-offs? Are they overstepping the steps or the curb? Take them to an unfamiliar intersection and introduce non-visual manners for crossing. Talk about actuated or fixed timed timed lights. I'm sorry, you know what I mean there. Pedestrian signals and other safety considerations that you think are important for them to recognize. Let them know about the white cane law also, and make sure that they have had a recent eye exam. If income is an issue, see if there is a low income sliding scale fee available with some optometrist, and go with them. I have done that more than once. Diabetic retinopathy, as you know, is prevalent here in the US. It is caused by damage of the small blood vessels of the retina, usually from high blood sugar. And according to the CDC, it is the leading cause of blindness among working age Americans. Individuals with diabetes should have a dilated eye exam every year. Only 2/3 of individuals who are diabetic do so right now. 90% of blindness in US adults caused by diabetes is preventable. That is a shocking statistic to me. That said, I know it's more difficult. I just think there's many ways that we could get there from here, and it's confusing and people get off on the wrong track. That might be a team approach. Okay, moving on here, be in the right part of my screen. All right, now let's talk about social determinants. I've been talking about different ages of people, different races of people, but how can health and vision loss be controlled or affected by social determinants, which are where an individual is born, where he or she lives, works, learns, plays, and ages. This is, to me, was so interesting. One key factor that will affect the simple necessities of life, will affect somebody's ability to access the simple necessities and pleasures of life, is simply economic stability, food, shelter, and healthcare. 1 in 10 elderly adults lives in poverty. And research has found that poverty is associated with poor health. This is true. This is very true. Community and social context, and how our social connections with family, friends, and community, and the strength of these relationships can impact our health status significantly. Think about what your friends do for their health and what they are paying attention to. Might be more diet related than other cultures and other communities. Different, Wisconsin eats entirely different than Virginia. I mean, hamburgers and pizza are prevalent around here. Not so much back home. I mean, you can always get pizza and a hamburger, but that's all I can get here. Sorry, and I do live out beyond bigger towns. Education access and quality. Individuals with higher levels of education are more likely to live longer, healthier lives than individuals who do not. So after I read that, I'm really thankful that my father insisted that I go back and finish that degree when I gave up playing the violin. I just wanted to drop out, but I'm so glad I went back. Access to healthcare is really hard for a lot of people. If you are blind and Richmond, any place that anybody that you wanted to live with was off of a bus line. So, if you wanted to live in the ghetto or in a really commercial section of town, good luck. But that's where all of the buses went. So that is changing everywhere. Paratransit has really helped with that, but some Americans lack healthcare insurance and do not have a primary care doctor or the healthcare to obtain necessary healthcare. Okay, I'm getting carried away here. The neighborhood, okay, so healthcare access, those without health insurance or primary care may not have the money to get necessary health care. Neighborhood and built environment, I just talked about that. I think where someone lives can greatly affect their health. Do they have access to clean water? Is their neighborhood safe? Is the air clean? Is the neighborhood safe? Is it, dirty? Is it toxic? So social determinants really impact health a great deal. Other confusing issues faced by seniors. The switch from employer-sponsored healthcare to Medicare can require a switch in providers, and it's complicated. And so I just learned that I'm not sure about this, but I think you have to actually sign up for Medicare, even if you're not going to take it at age 65. So how many people really know that? I didn't know that. So it's complicated. The system is complicated. And unless you have an advocate as a senior, you may not really know that. So just keep that in mind, that there are a lot of switching, confusing transitions for seniors that they're not expecting, don't know where to go to get the information, and, just miss. Transportation to and from medical providers could also be an issue, especially for those living in a rural area, which I do. So most of my providers live, not all of them, but most of them live further than 15 miles away. It is not uncommon for me to drive 100 miles round trip to see a provider, to get my teeth cleaned, anything. It's sometimes people just can't drive anymore. If they get too old, they can't drive. They're not safe to drive. They can't get transportation. Paratransit doesn't go in their communities, etc. So sometimes transportation is a huge barrier. They don't have family to help them, or their husband just died and she doesn't know how to drive. There's all kinds of scenarios where transportation is an issue. The U.S. Census Bureau notes that the average out-of-pocket annual expense for adults over the age of 65 was $7,000 annually. That's a lot of money if you're on a fixed income. So these are confusing issues, often not surmountable, that are faced by seniors in our lives and on our caseloads. Let's talk about mobility. Done with the background, growing old information. So you get that referral. What do you do next? You get a referral, and what do you do? And first of all, we know that you're expected to operate within the expectations of your employer. And each institution is different. Try to make sure you're absolutely sure of what those expectations are, and see if you can get it in writing. If you work at a VA, you get a consult, and it could come from anywhere in the hospital. And it is possible that the consult will come from someone that you don't even know about, who doesn't really understand what you do. If you work for the state, you could get a consult, again, probably from a counselor who knows you're in the area and has a client in that area. You never met them face to face. You know nothing about this client. If you know You know they're not a veteran because you're not, they'd be at the VA maybe. So there's certain expectations there, and you have to operate within those expectations. A nonprofit is the same thing. I have worked for a nonprofit one time in my life, and it was unclear to me what the expectations were there, but they were entirely different from anything that I ever experienced at a state organization or at a federal organization. So you may want, if you start new employment, make sure you understand what is expected of you when you get a referral, because you will have referrals for people who are not even legally blind, not even that visually impaired. They just can't drive anymore, or they're just experiencing difficulty with glare and lighting, or something. So just make sure you understand what the referral is. Whatever you do, err on the side of caution when you get that referral. You want to get an idea of what the referral is for and what the client's capabilities are before you meet them. You don't always have time, but do the best you can with what you got. There is no IEP listing what you need to do, and usually no listed goals. It's where they live, basic information, and hopefully it will have their age and other medical conditions, perhaps, especially the eye condition. So make sure you understand what the referral person is asking for. Or what is their expectation? Is it even an appropriate referral? Is this a person who is blind? If they're not blind, do they have a visual condition that, and what is it? Do they have a blast injury issue? Do they suffer light sensitivity? Do they have nystagmus? Is there something, is it, just figure out what the referral is for. Can you contact the referral source to clarify it? And remember, your referral probably has an acquired condition. You can expect them to be in denial, and they may not give you much information. They may not even know what their condition is. Again, expect denial. They don't want a white cane. They don't want a white cane. A couple came in to Duluth, and the woman was clearly, she had, very dark glasses on. I don't even know if there was any light getting in. They were so dark. They're just really dark. And she obviously was walking very slowly, and she had to hold herself very straight. And I listened to incidental comments. And by the way, she had a walking stick, and I think it had a pick at the bottom of it. It was not appropriate for a hardwood floor, but a walking stick, not any kind of a cane or a white cane, but a walking stick. Now, maybe that was appropriate, but she had a visual impairment of some sort, and she became very dizzy. And, anyway, I wanted to tell her the story of the purple glasses, which I will get to in a minute, and just let her know about, just let her know some of the services and what type of optometrist, behavioral optometrist, might be able to help her also. And she brushed me off quickly and said, I'm working with a physical therapist. And she probably needed to do that for her body movement and her being off balance. But I did want to tell her some vision related issues that might have helped her, but she just didn't want to talk to me at all. Another thing that you can expect with denial is they may only have a 5-degree visual field, but they may still be driving. And so that's something you have to confront and consider. And are you legally required to call DMV and let them know? Some states have it do that differently? I don't know. I've never done that, but I've always um, I have not taught students who are still driving, but I have heard about it, and it's always a concern because someone with a field impairment may be a little more confident than they should be. Moving right along. So, if you are dealing with somebody who, like that woman at Duluth, I wasn't going to talk with her because I was doing my job. But had I been in a different situation, I might have simply changed the subject quickly and then come back to it. Or I would have handed her something to try. I would have handed her the purple glasses and reported what they did for the client that I'm going to tell you about in a minute. Maybe hand her a vision device, such as this. I use this to walk outside late at night when I'm trying to look for a cat or a dog or something, and I can walk with my hands free. And it's nice to have a flashlight that's hands free. So I have them all over the house now. But we sell these at Duluth, and I really like them. And they go like this, so you can turn it up. And anyway, um, if you can identify the denial, give them information, uh, give them your card, and just document. So if you have a client that you know isn't ready, provide them with information, see if you can get them to meet again, offer a Glareware assessment, offer intersection analysis or something to make their walk safer, whatever. But then you start digging. So you get this referral.
Hey, Nancy.
And yeah.
It's Megan. I just want to do a time check and let you know we're at 2:15 and we wrap up at 2:30.
Oh my gosh. Okay. Gosh, how can I talk so long? Oh my gosh. Okay.
We can
Start
always
digging.
do a part two.
Okay. If there's an eye report, look at it and try to develop rapport with somebody who can tell you what that eye condition is. What are the acuities? Are they even legible? Probably not. I've looked at so many eye reports that weren't typed, and it was really hard to make out what the acuities were. Is the referral legally blind? And this might be important depending on where you work. Also, if they are legally blind and they are veterans who did not qualify for VA health care, once they become legally blind, they're in, and they have access to the best blind rehab services and low vision services available, free. When did vision loss occur and what training has occurred to date? These are things you want to start digging for and understanding. Are they still in denial or resistant to services? What secondary disabilities and chronic conditions might there be? Make sure you understand this. Is there a PT or occupational therapy needs? Do they have neuropathy, arthritis, or amputations? Are they diabetic or on dialysis? Do they have any foot, hip, or leg problems? Heart issues, pacemaker, Alzheimer's, dementia, mental illness, hearing loss. Hearing loss is huge, and if they're a veteran, they probably have hearing loss. And you can receive hearing aids free if you are deemed to be service connected for hearing loss. Period. So if there is a hearing loss and you do believe they can track where that injury occurred or where those loud noises occurred, and if they can connect them due to hearing loss, there may be a monthly stipend for that, but I also get free, free hearing aids. Another thing you want to know, are they capable of independent travel or safe travel? Have they fallen recently and is it vision related? And is there a history of falls? And this is really important to know. I had an elderly friend who just died. And when she became ill, she called me one morning, 5:30 in the morning, and she says, I fell, I can't get up. And will you come help me? You're the only one I know who's up this early. And I did. I went into town and I helped her. And she was so heavy. I had no idea how heavy. She's just a little thing. And she's heavy. So if somebody has a history of falls, please be careful. Do not risk it. How did they travel to and from the site? Cane, a walker. Make sure you notice all of these things and then ask them, can you walk 50 feet? Can you walk a block? This is huge. You don't want to get out there and realize this man can't walk more than 20 feet because it's not safe. And you don't want them to fall on your dime. If there's a chance that the person is unsteady or has balance issues or has a history of falls or is unable to function independently, steer them accordingly during your assessment. Don't do anything that will cause harm. That's the first question that you should. When was your most recent fall? That'll do it. What is your greatest visual complaint and when was your most, have you fallen recently? When was your most recent fall? And if it's a veteran, look to the wife and see what she's doing. She might be nodding her head. A lot of veterans are proud and they don't want you to know. A lot of men are proud and they don't want you to know. So notice anything that the wife is doing. Let's see. Now I'm talking about calling to make you call to schedule. These are a little bit backwards. Okay, let's just, you call to schedule. I don't ask any questions. I just schedule them. Okay, why is this going? If you are meeting them in the home, I would take plastic gloves, a mask, maybe lots of alcohol swabs and some sort of disinfectant just in case, you never know. Wear something that is easy to clean and in case of shedding animals, and you might want to take an extra outfit just in case. Take some low vision devices or glare glasses or lighting devices, light bulbs or flashlights, and an acuity chart and other evaluation tools that you use a lot. If you are in your office, I have to tell you that your office environment could be crucial to what they tell you. And I learned this when I was the polytrauma bros and working with the brain injury population. They were so light sensitive that I had no overheads on. I just had one desk lamp and my computer and my little, desk lights. And they walked in and they just breathed deeply. And they would sit down and they were comfortable. They weren't going to get a headache from the overhead lights. And all of a sudden, they would tell me anything. Little bit of dark lighting and the question, tell me what is the chief complaint that you have regarding your vision? Well, it all started when. And it would go for hours with that. But it was really interesting to hear about their time in the service and what they've done since and what they experienced visually and what we could do. It was great. It was an awesome way to build rapport. And then I would give them something that they could, that would help. Let's evaluate lights for night driving. I'm just going to turn the lights off here. We just got a few more minutes. I'm going to shine a few lights here and you try these glasses on and see if they help. See if you can see that without getting a headache. And it was the best environment. I'll tell you, if you turn the lights down low, Matt will tell you just about anything. Just saying. That was meant to make you laugh, but I can't hear that. So, all right, wait a second. I'm moving along. I know we're running out of time. So the evaluation should always be, what does your boss require or allow? What does he expect? What are you allowed to do or not do? For example, at the VA, I could not put down an acuity that I had take a functional acuity. I couldn't put it down because that was what the doctor did. So I would say something like acuity OD appears to be about 1040, So it couldn't be anything like that. I might comment on the lighting in sunlight, able to see 2200 screen, blah, blah, blah. All right, so where are you meeting them? At their home or place of employment? We already talked about that. My evals will consist of historical information with or without an assessment, a functional vision evaluation, a safe observation, some sort of a demonstration, and a formal plan based on their needs, goals, and abilities. How are we doing on time? Well, I'll keep going.
We have 7 minutes.
Okay. Should we ask questions? Should I just open the floor for questions, or should I keep going?
I think see if there's any questions, and if there's not, keep going.
Okay. How do I tell if there are questions?
They can put them in the chat or just shout them out since it's a small group.
Okay. All right. Okay. No questions. Okay. So historical information, if possible, I try to include everything that I dug up. It could be just a sentence. I'm sorry, a paragraph, but met with veteran who appears to have a diagnosis or to be legally blind secondary to macular degeneration. Secondary disabilities include diabetes, neuropathy from, neuropathy in feet, hand neuropathy, whatever, hard of hearing, anything, family makeup, race, ethnicity, social environment, eye condition, legal blindness, no light perception, low vision, current mobility devices, and or level of an independence are things you could all include in historical information. Then you meet your client. And again, one of the first questions I ask any senior or adult, have you had any recent falls? And do you experience any state of dizziness when you stand up or sit down? What is your chief visual complaint? What is their mobility goal, or do they even have one? Do they have family, community support sufficient to offset their visual disability? Next, I'm going to do a functional vision eval. This is going to be a confrontational field and acuity. I might use the TAPS assessment. I worked hard to get the right assessments over the years. Other things that you can notice, I'll let you look at these. I want to tell you about the purple glasses. So I'm looking to that screen. Oh, if you do observe somebody, make sure you evaluate them on stairs and see where they put their feet. Do their toes go behind the step? Their toes should not go beyond the edge of the step. They might have neuropathy. Try to make them aware of this. Just an important observation. Documentation. This will all depend on, we won't talk about this, but I have a lot to say about it. I want to talk about these, but that's not me, by the way. These purple glasses I have to tell you about. Noir sent me a pair of these purple glasses when they first were evaluating them, and they were called the SF glasses. They were later labeled to be number 72. So I handed out the SF glasses to a gentleman who had just been referred to me. I had no idea what his visual needs were. I just met him. I don't know that I had done much with him at all. And he wore those glasses for a week. And then he said to me, you know what? I'm not having vertigo anymore. So apparently he had been experiencing vertigo since he had his head injury. And all of a sudden, he was able to function. He had been a couch potato for years, and then he could function. So we decided, and he wore pair number 38, which were over his regular glasses and yada, yada. So we asked Dr. Peterson to prescribe glasses that I could send off to Chadwick Optical and have made in purple with that prescription in it. So we did that, and we got it made in a nice pair of glasses. And Chadwick Optical sent back a pair of purple glasses with the same light transmission rate, blah, blah. All of a sudden, his vertigo comes back. So I called Charlie at Chadwick's Optical, and I'm like, dude, what's going on here? How come they're not working for him? And Charlie Chadwick said, I have no idea. Those glasses are the same purple and the same light transmission rate. I can do that. But Noir has some machines that we just don't have, and they can do all kinds of things. So however these glasses were made, they took his vertigo away, and it was life-changing. Just like my going back to school for mobility was life-changing for me, these glasses were life-changing for him. Just some incidental, here, try this. So you never know. The end result of this story is we got a pair of clip-on flip-ups, the frame that you can just attach to your glasses in this particular color, which you can do with Noir. And he functioned well, and he had his life back. I can't tell you, that is the most satisfying, I've just never experienced such a satisfying, I can't tell you how much I appreciate what you have done for me. That is the most, I forgot his name, but I'm just so thankful for that experience, and that I just, on a whim. Okay. I'm sorry. I'm done.
No, that was good. That was a good wrap up. Well, thank you, Nancy. Before we close out, are there any questions or anything from the audience? Such a quiet group today.
Well, I don't think anybody left.
Can we? This is Rebecca.
If you had, I would have had to go home and.
Hey, this is Rebecca. Can y'all hear me?
Yes.
Yes. Okay. Yeah, I just want to get your contact information.
Yeah, sure.
I've been working with kids for all these years, and I'm moving to an area that's mostly seniors. So I
Yeah.
want to start something, and I really
Yeah.
could use your
Sure.
advice on all of
Sure.
it. Okay.
Sure.
Great.
I love it if you contact me by cell phone,
Okay.
but text me. The area I live is so remote,
Okay.
and I don't always go online, and I only get like 100 emails. So, I
Right.
might not see it for a while, but 804 304 804 304 8438, and anybody can text me. I don't always answer, and don't expect an immediate answer, because I do, sometimes it'll take hours before I'm actually, depends on where I am.
That's great. And would you be willing to share this presentation as the what do you call it?
Yes.
Just the slides, that'd be great.
I don't mind. Just
Okay.
please don't tell them who I am. I don't want them to,
Oh no, I'm not going to present it. I just want to reread it.
Oh, no, please
Okay.
go ahead. And please feel free to contact me,
Great. Thank you.
Yeah, anybody. I'm also in Janesville 3 days a week, so I might get your text right away.
Molly in the chat said, would it be possible to read those slides again? Molly, which slides are you referring to? Okay, well, I'm waiting. You made Joycette, I'm hoping I'm saying your name right. You made Joycette laugh. Benjamin says, thank you, Nancy. Would love to connect as well. Oh, love
Please.
for nonprofit. And there's a bros in the VA Tampa.
Yes. Oh my gosh, I got to talk to you. My friend that recently passed, he worked he was in Florida too. So I'd love to talk to you, please. And here's an email that I don't use very often, so it won't be flooded, but feel free to use it if texting isn't convenient. NPRUS004@gmail.com.
Yes, cheese is a closing code, Wisconsin is the opening code, and I'll send an email out probably early next week with the evaluation link, and I can send if Nancy I think has a link, and we can send the slides as well. Oh yeah, Molly in the recording. Because Molly, do you just want the just the slides to review? Is that what you meant by reread the slides?
Miss Megan,
Yes.
aren't you going to post it?
Yes.
Isn't it going to be put? Yeah.
Yep, we'll reread the recording. Can we, Chris? Okay. Yes. Okay. Very
No,
good.
no. I'm sorry. It's NPR. It's NPRUS. The NPRUSing account is the one that's flooded too much. So it's NPRUSS004@gmail.com. I'll write it. I do have another one that I access all the time because I only get, but that's the one that I just, sometimes I have 50,000 emails in there I have to clean out. Is the sound working still or not?
Yes. I was
Okay.
just typing, I was just responding to a few messages.
Okay.
Oh, I sent you. Oh, I put in you're wrong. I wonder if I can. Oh, good. I can delete. I added.
Okay.
I ad-libbed to your email. Okay,
It's
yeah.
all
So
right.
the slides will come. The slides will come with the evaluation, and I'll put Nancy's email in as well for any
Yes.
questions too.
Yes.
So
Thank you. It's been really
cool.
fun.
Yeah, okay. Well, thank you everyone for coming, and we'll see you soon probably. So
Thank you,
we'll have
Nancy.
another
Thank you.
in January. Okay, bye everyone. Have a good
Thanks.
day. Thank you so much, Nancy.
Yep, you bet.